Hello, I'm Dr. Traci Wolbrink, a pediatric intensivist at Boston Children's Hospital, and I'm here live on stage in Hyderabad, India at the PEDICRITICON 2025, the 27th National Conference of the Indian Academy of Pediatrics, Intensive Care Chapter. I'm delighted to be on stage today doing this live podcast with India's top pediatric critical care medicine researchers of 2025. I'm just going to have the authors start by introducing themselves.
Hello, good afternoon. I am Dr. Ashish Agarwal. I'm a pediatric intensivist currently working at Cloud9 Hospitals at Panchkula. I have done my MD Pediatrics from PGI Chandigarh, then did my senior residency in PGI Chandigarh, and then my DM in pediatric intensive care from PGI Chandigarh. Currently, I'm working as a pediatric intensivist in Cloud9 Hospitals in Panchkula, Haryana state.
Wonderful. Lovely to meet you, Ashish.
So good afternoon all. I am Dr. Rameshkumar Ramachandran. I am currently working as a consultant pediatric intensivist and associate professor in the Medical University Hospital in UAE, Dubai. I passed out from MD and both DM from PGI, the same from, and under the great leadership Dr. Sunit Singhi sir. And when the study was conducted, I was the part of the faculty in the institution. And currently I moved to the Middle East. Yeah, thank you.
Wonderful. Well, thank you so much. I'm very excited to speak with both of these authors today about their randomized controlled trials. So Dr. Ashish is the first author on the study of 0.9% saline versus Ringer's lactate as initial fluid in children with diabetic ketoacidosis, a double-blind randomized controlled trial. I was hoping you can tell the audience in maybe 2 or 3 minutes about your key findings in the study and what you found.
Thank you, ma'am. So, as we all know, we use normal saline day in and day out in our clinical practice, both in emergency and ICU, we use normal saline. But the question is this normal saline really normal? So, this normal saline, which has a sodium of 154, chloride of 154, it is slightly hypernatremic compared to plasma, but highly hyperchloremic as compared to plasma. The plasma, which has a chloride of around 100, NS has a chloride of 154. So it is highly hyperchloremic as compared to plasma. So there has been this recent talk and there is a mounting evidence on the deleterious effects of this normal saline, both in critically ill children and adults also, in various settings like in septic shock or because it is being commonly used fluid for resuscitation. A growing body of evidence suggests that it leads to hyperchloremic metabolic acidosis and its deleterious effects on the kidneys also, like it causes renal vasoconstriction and leads to AKI and causes acid-base imbalance. This hyperchloremic acidosis is even more important in case of diabetic ketoacidosis. In diabetic ketoacidosis, already they are prone to have hyperchloremic acidosis because of preferential renal excretion of ketones over chloride. There is a osmotic polyuria, and on top of that, if we give these children, if we resuscitate these children with large volumes of normal saline, this chloride rises and leads to delayed in resolution of the decay. So taking this into the background, there was a recent interest in using balanced fluids. So balance is the key mantra nowadays. So the balanced fluids, people have used plasma light and Ringer's lactate, etc. So what we use, the hypothesis was the Ringer's lactate, which has a chloride of around 100, and the plasma also has around, so it does not lead to hyperchloremia. Also, the lactate anion in the Ringer's lactate goes into the liver, gets converted into bicarbonate, and leading to early resolution of the acidosis. As WHO also recommends Ringer's lactate as a fluid in cases of acute gastroenteritis, and this is the physiology which is used that lactate ion gets converted into bicarbonate and leads to early resolution of the acidosis. We use this hypothesis, and we tried to randomize children between around 9 months to 12 years who presented to us in diabetic ketoacidosis. We randomized them to receive either normal saline or Ringer's lactate as a fluid, initial fluid, both for resuscitation also deficit correction, because in resource limited settings or in developing countries, the scenario is different, where most children present late because of late diagnosis, late referral. They present more in severe decay than in milder decays as in developed countries. So in such children, if we use large volumes of normal saline, this can lead to those problems. So when we randomized, so we plan to randomize these children into normal saline group and Ringer's lactate group. What we found that in the Ringer's lactate group, there was early resolution of diabetic ketoacidosis. It was around the mean duration of time to resolution was 13 hours as compared to 17 hours in normal saline group. So, and also the secondary outcomes like the rise in chloride, the hyperchloremia at 4 hours and 8 hours of randomization was significantly high in normal saline group as compared to Ringer lactate group. Also, the rise in bicarbonate was more in the Ringer lactate group at 12 hours of randomization. So, having this pathophysiological basis, this led to our primary outcome where there was early decay resolution in case of Ringer's lactate as compared to normal saline. So these were the findings, and subsequently now there has been a recent change in guidelines. Also, the ISPAD previously used to recommend normal saline both for resuscitation and deficit correction, but the current guidelines of ISPAD, recent guidelines also say if the child needs resuscitation or bolus, then it is better to use balanced fluids, and the deficit correction can be any fluid between 0.45 to 0.9% saline.
Fantastic. Thank you so much for highlighting the key features of your study. And just a couple quick follow-up questions. Have you changed your practice? Do you now use balanced solutions?
Yes, ma'am. So we have changed in our unit. Like ours is a very busy unit. Like we operate around 500 to 600% of the occupancy. We have somewhere around 100 to 120 diabetic ketoacidosis per year. Previously, we used to use more of normal saline, but over the past couple of years, we have changed our practice. We are using more of balanced fluids, and we are using more of Ringer's lactate. The challenge is in resource-limited settings is to get plasma light. It is slightly costly, but whereas Ringer's lactate is readily available, like it is a readily available cheap fluid which is commonly being used for acute gastroenteritis. So we have started using Ringer's lactate in place of normal saline in those sick children who present in severe decay and those who are at risk of developing this hyperchloremia and AKI. So we have changed this practice now.
Fantastic. And you use it both for the boluses as well as for the ongoing maintenance fluids as well?
Yes, ma'am. Yes. So the deficit correction, also the bolus, we use Ringer's lactate.
Fantastic. Well, thank you. And now I'm going to turn to our next speaker, and Dr. Ramesh Kumar, who is an author on the high flow nasal cannula versus nasal prong bubble CPAP in children with moderate to severe acute bronchiolitis, another randomized control trial. I was hoping you could tell us a little bit about your study.
We all know that acute bronchiolitis is one of the most common respiratory illness presenting in the emergency and PICU. And previously, the standard of treatment is supportive only. Then second thing is the humidified oxygen is the treatment of choice ultimately. So how we are going to deliver the humidified oxygen is the question. So previously we used for this indigenously is made some kind of CPAP system in the setting in the busy emergency and try to avoid intubation. That is our ultimate goal because of a limited number of PICU beds, particularly limited number of ventilator beds availability. Then most importantly is the cost, subsequent cost environment. So then recent couple of years, the high flow nasal cannula therapy is gaining so popular. Okay, so the question is, the indigenous bubble CPAP setup is hardly taking hundreds in Indian rupees, and versus in the high flow and other way is in lakhs to invest in the messing and consumable in thousands, couple of thousands. So we decided to compare head to head. So is it going to make any difference in the terms of treatment failure and requiring what is called non-invasive ventilation or invasive ventilation, basically respiratory support escalation. So we randomized in the two group, like 1 month to 23 months, presenting with moderate to severe bronchiolitis and requiring further respiratory support. One group is CPAP, begins with 5 centimeter, maximum 7 centimeter. Another group is high flow, the flow based on the weight. Titrated at the end of 24 hours, the HFNC group found almost the failure rate is only 23%. But in compared to that one, the CPAP group is almost 47%. This is really significant. And another important thing we found that the escalation to the ventilator support, in particularly non-invasive ventilator support, also significantly is lower in the HFNC group. So The one another important thing is the products in this study is the median duration of the oxygen therapy and hospital stays 1 day is higher in the HFNC group, but it could be due to because of the some variation in the weaning protocols. But in the study purpose, we used only FAO to wean first, then flow later. So, but still, we need to study separately the weaning modality in the HFNC. I hope this one of the author in the study is planning for that one. Will give more answer in the future.
Fantastic.
Okay.
And the same question to you. Has this changed your practice? Do you use
Yeah.
exclusively?
I'm I am for HFNC guy now because I used to HFNCs now when almost all the bronchiolitis, including post extubation, everything is HFNCs making one really important modality is preventing the intubation and ventilation. So since beginning we are using HFNC only. Yeah.
All right. Well, now that we've heard a little bit about the studies, I want to dive a bit into the conducting of randomized controlled trials and some of the challenges that can be associated with doing this type of research. Now, I attended the Pediatric Research Networking session yesterday, and we talked a lot about research here, the current state of research in India, and goals for the future. I was hoping to kind of start illuminating, first starting with maybe some of the challenges to doing these kinds of studies. And I think, honestly, the challenges that you face are the challenges that everybody faces around the world when trying to conduct a randomized controlled trial. But maybe, Dr. Ashish, I could ask you, what were some of the challenges that you faced as you were trying to implement this study?
Thank you, ma'am. As we have discussed, our trial was conducted in a resource-limited setting where we have, as I have told, we operate at around 500 to 600% occupancy in both emergencies, and we are very busy PICUs. Most important challenges which we face in conducting such trials is one is logistic issues, the resources, and also the manpower issues. So just to point a couple pertaining to the study. This study required the trial fluids, that is normal saline and ringus lactate. So the fluids generally in resource-rich countries are supplied in collapsible bags, air-free bags. But most centers in resource limited settings, the IV fluids are supplied in rigid plastic bottles, which are non-collapsible. It is very difficult to blind these fluids by wrapping them in a foil paper and then using them for this thing. So it was quite challenging to get those Baxter bags. Or so just to point a couple. Another thing is like we wanted to do ketones every 4 hours. So there is no steady supply of those point of care ketone strips. So main thing which we face challenges is the logistic issues, or the resources are limited. And in whatever limited resources we have, sometimes we have to spend from our own stipends and get these resources to conduct these trials. Also, very, very important thing is the manpower. The residents, the nurses who are working in setting like us, they are quite overstretched in both their clinical responsibilities. Each and in a busy emergency room where one bed has 3 to 4 children who are critically sick, and when nurse is looking after so many children. But most important is when we conduct such trials, we have that very good team effort. They stretch themselves beyond their responsibilities and help in conducting these trials in a smoother way, in a protocolized manner. So they help us out. So the residents who are working day in and day out, most of the residents who are working in while doing these trials, they're working 16, 18 hours a day, helping other colleagues to conduct these trials and enroll children, collect data. So we don't have dedicated research manpower to conduct such trials, ma'am. So that the resources are less, the manpower is less, but still, despite all this, like we give our more than 100% to go beyond and collect the data in a more in a very protocolized manner and conduct such trials. We should love what we are doing. We should give our heart and soul. So then we can stretch that extra and get all the data and conduct a trial in such resource limited settings. The positive point which I see is we get a good number of cases. and sicker case. Suppose diabetic ketoacidosis in developed country, they may not present in severe decay. They will not present with pH of 6.8, 6.9 as routinely they present with us. Like in diabetic ketoacidosis, most of our children present in very severe decay. Most children like in our trial, around 3/4 of the children had a pH of less than 7 at presentation. So the mean pH in around 3/4 of the children was 6.8, 6.9. So it is good that we get such load of cases, and we are able to conduct such trials where the fluid, which is the main which is the main debate on which type of fluid. So we have those cases, and we are able to do such trials.
Well, thank you. I mean, you highlight so many things. You highlight the resource constraints, the manpower constraints, but then the fact that, this really is a labor of love, and being passionate about it sounds like you're able to mobilize a team to work with you and be collaborative. And, there's a greater good that we're sort of working beyond. One other question that I had related to you, I attended and helped facilitate a workshop that Dr. Rakshay Shetty designed called SIMPACT, where we talked about the use of simulation for quality improvement. And I wonder, as you were describing all the different challenges that can go wrong with your protocol, with implementing this, did you do any dry runs or practice or sort of think about running through any of those activities, similar to what we might do with simulation and sort of systems testing or practicing? I'm curious how that rolled out.
Yeah. So a couple of months before we started, we started enrolling children. We every day we used to go around emergency and ICU. We prepared all the pamphlets and all. We have displayed everything that such a trial is going to start, and we all the nurses, all the resident doctors were initially told that we are going to do this trial, and if any child of diabetic ketoacidosis comes to emergency any time of the day, whether it's 2 a.m., 3 a.m., whatever time of the day, the principal investigators will be called. He is going to visit the emergency, enroll randomize the child, enroll. So yeah, definitely all these things help. We had done this thing before starting the trial, and then we started up.
Fantastic. I thank you for highlighting the amount of work and practice and run-throughs that you did in advance, because I think when you think about a study, you think you write the protocol and then magic happens and the trial begins, but there's a lot of work up front to get everything started. All right. And now turning to you, Dr. Rameshkumar, I was hoping you could describe some of the challenges that you faced as you were sort of working through your study and implementing that.
Yeah, definitely there is a logistic issues in this busy emergency room, but the previous experience what we conducted a couple of studies in the RCT, so that gained a lot of knowledge and experiences. So in the study, writing protocol, and then we decided, because we are already using bubble CPAP, we are already using in the HFNC. So when we are finding for weekly review or monthly review, and what is the problem happening in this modalities when patient is going on care. So that is, then we find out one or two things, but specific to the study, we need to ensure the consistency in the setting up of nasal prong, and consistency in setting up of the 5 centimeter PEEP, then consistency in the escalating. That is the very toughest one. So before study, so we test run, for example, around 5 to 7 patients. So because when studies comes, this all are important. So we did some test run. So we find it is feasible. There's no issues, and that has helped us. And the other thing is we need to consistently deliver the consumable for the high flow, because as per our ethics committee, the study should ensure everything to the patient. So we secured the institute support, intramural grant support. So that has helped us. And after completion of the studies, of course, we know that once the RCT's writing protocol is tough, but at the end of the day, writing manuscript is not a much problem, but execution is the more important. So we found these two is very important hurdles. So from that, what we learned that, so whenever we are going to plan it, so our fine tune our writing protocol, writing skill for next RCT, because next RCT is planning for weaning modality in HFNC. So we fine tune our writing skill in the protocol itself, each and every points like introduction, methodology, how to deliver, and now we are put it test run incorporated in the protocol itself. We are going to test run this particular protocol for a couple of patients, and with prayer approval from the ethics committee and all those things, it's going to help us. I hope it's going to help us. Okay.
Fantastic. One of the things that you mentioned was trying to standardize your protocol, being more exact in the way that you deliver care. And I'm curious about whether or not you think it has made a difference in the type of care that you deliver. Oftentimes, studies are great opportunities for us to change our practice and sort of get on board with different checklists and protocols and improve our care because we, are paying really close attention to that. I'm curious if you saw any changes even beyond the study period that sort of lasted in your ICU.
Yes, because what I'm saying is this is the residents will keep rotate. Okay, so during the study period, the particular residents will be there. They are aware about the studies going on and how meticulous we are about the setting up the people, what is called CPAP level 5 or 6, everything. Then subsequently, we inform or we do need to train them, we need to come what is called teach them the new resident. Otherwise, we will lose the track because when study is there, we will penticularly measure the scale with everything, 5 centimeter. When study is not going, okay, even approximately they can, because the resident mindset is totally different. Okay, so I observed in the couple of almost 6 months to 1 year, when we are conveying our the points to the residents, they are also happy and they learned. So for me is when we are going to delivering the care, so this study made us to fine tuning. So this should be implemented in your routine protocol, in the care. So how meticulous about your CPAP setting and how meticulous about your measurement and all those things. So otherwise we will lose the track after 6 months or 1 year. But I observed that couple of 6 months, this was fantastic. And I hope that the other author will might continue the same.
That's great. I think we often talk about how, there's clinical care, there's research, but I think what you've highlighted is just the fact that research, both of you, research informs the clinical care that you then go on to deliver afterwards. And it can also make practice changes in your unit that can help deliver clinical care even better. So just the fact that participation in research can increase both of these, I think is really exciting and leads me a little bit to my next question, which is any advice that you have for junior trainees as they get started or junior faculty about, the importance of doing research, any tips or strategies about how to get started or stick with it when it might be challenging?
Yes, ma'am. So as you have rightly said, when we do research, for example, as the previous point, if I come to the previous point, my mentor, Professor Jayshree Muralidharan, so she has done most of the research in diabetic ketoacidosis. So we have tested insulin dose, type of fluids, volume of fluids. Now, in the unit, there is a set protocol. There is a standard operating protocolized care. Each junior resident also knows that if a child with DK comes, what are the steps which are to be done. So doing research consistently on a same topic has refined that care in the unit. There is no difference in the care which the practicing physicians or the residents provide at the ground level. So each and every resident knows that if the child with diabetic ketoacidosis comes, then these are the steps which are to be done, which are being done since a decade, because all of this research has been done. So for junior colleagues, the thing is definitely with experience, we can say that doing research helps us to know what are the challenges at the ground level in the patient care, whatever the care which we are providing. We also come to know the challenges when we do research, because we want to do it as per protocol. And that time we know that these are the things which get missed in those busy emergencies or ICUs, and definitely it helps in refining yourself in clinical practice. So definitely yes, but the most important thing is you should love what you are doing. So the research topic which you choose is you should love that. Yeah, this is the topic which I want to do. So before joining DM in pediatric intensive care, I always dreamt of doing some topic in fluids. I was very it was my dream to do some thesis in fluids. So and when I joined, and then when this thought came from my mentor, she said that we'll test type of fluid in diabetic ketoacidosis. I felt that this was a dream come true, and then I gave my heart and soul to this research. And I'm really happy that it got recognized in an international journal, and we're able to make difference in our clinical practice.
Fantastic. I think you outlined a few things. One being passionate about your particular topic. One of my mentors always told me that you have to do something that really makes you want to get out of bed every morning and come into work. And so it sounds like Fluid is that for you. You also mentioned the importance of mentoring. And I'm curious, how do you find a good mentor? What makes a good mentor? What are some of the things that people should be looking for in a mentor?
My mentor, Dr. Jayshree Muralidharan, I don't have any words for her. Like whatever I'm here is all because of her. And also the grades which were sitting, Bansal sir, Singhi sir. So what they do is they will give you a topic which you are interested in, and they will not interfere. They will give you that independence of doing that research, and whenever you are stuck in some administrative issue, logistic issues, and then they are going to help you out in all those problems. So obviously, yes, a good mentor is the one who recognizes that what his students loves, the topic, what he or she would love to do, and then nurturing that thought and then taking it further.
And for you, last, any comments, words of advice for junior people that are getting started?
Yeah, the most important part is when I'm going to some particular unit, first look at the feasibility. Is it feasible to the particular study in that given unit, number one, looking at the data, previous year data. Then you can go for that further writing up the protocols with the help of the vendors, and of course, definitely they will available for this one. And I emphasize more of the writing the protocol, make it as perfect as possible. Okay, there once the protocol is done, then give some test run, then do modify again, whatever modifications. Then once study started, stick to the protocol, try to collect the data meticulously. Then thereafter there is no stop. Okay, whatever the result, whatever the discussion, doesn't matter. So feasibility is the topmost priority for me. In the given city, the given resource, so what I can do. Okay, because I may do many wonders, but even many small things, even the routine clinical practice data, if you analyze properly, collect properly, it will make wonder, definitely.
That's great. I think those are such important points that you have to be realistic about the research that you can conduct, what is going to be reasonable in the time frame you have, with the resources you have, with the mentors that you have and the team that you have. And then when you bring all of that together, you can be passionate, you can start writing, you can get that out very early, is what I think I hear you providing advice.
Because my resident, when I was resident is RCT, guided by Dr. Singhi sir. When I was in fellow, again RCT, so guided by Dr. Bansal sir and Singhi sir. So really learned a lot. So the made me is I'm one of the interest in the clinical research. I love clinical research. So they guided me a lot of thing how to go, where to go, get it, all the stuffs done. So attended many clinical research workshop and everything. So the end of the day, the protocol is everything. Okay, so protocol. Okay, then we can execute and other things different. Okay.
Well, thank you both for sharing your insights today on I think the first ever podcast we've done live at PEDICRITICON. So thank you for being the inaugural podcast guest, and thank you to the audience for joining us today.
Thank you very much.
Thank you.